Okay, so welcome back to this next video in which we are discussing diabetes mellitus and anti-diabetic drugs. Okay, right, so we're in the process of discussing the different types of diabetes mellitus. We've just discussed type 1 diabetes mellitus. Now what we're going to discuss is type 2 diabetes mellitus. Okay, which is by far the most common type of diabetes mellitus, far more common than type 1 diabetes mellitus. Okay, I should have said that type 1 diabetes mellitus is generally seen in people under the age of 20. It can be seen developing in people older than that, but it is generally a disease that affects children and also adolescents. Okay, and it's the main form of diabetes mellitus that affects people under 20. Although due to the rise in obesity, we are now starting to see type 2 diabetes in people under 20, but previously type 2 diabetes was reserved to adults. Okay, right, so let's discuss what happens in type 2 diabetes mellitus. Okay, so initially, type 2 diabetes mellitus is not a disease of the beta cells of the islets of Langerhans. Initially, they are absolutely fine, okay, and they're producing insulin as normal. Initially, what happens is a phenomenon known as insulin resistance. Okay, now what this means is that the beta cells of the islets of Langerhans are producing a perfect amount of insulin. They're doing exactly what they were supposed to do, okay, but the peripheral tissues that respond to insulin, okay, such as the skeletal muscle cells, the liver cells, the adipocytes, are going to stop responding to the same extent. Okay, so there are problems with the pathway downstream of the insulin receptor. So the insulin still binds to its receptor, but now the insulin receptor isn't capable of triggering the same downstream pathways as it was before. Okay, so the effect that insulin has on the cells of the liver, the skeletal muscle, and the adipose tissue is going to be reduced. Okay, now once again, let's think of what this is going to do to both our fasting state, glucose homeostasis, and also our fed state, blood glucose homeostasis. Okay, so we'll start off with what it's going to do to our fasting state, blood glucose homeostasis. So let me get the picture back again. So here is our fasting state, blood glucose homeostasis. So we're familiar with this by now. Okay, when you are in the fasting state, euglycemic blood glucose is present, okay, and this triggers the alpha cells to release a lot of glucagon, and the beta cells only release a little bit of insulin. Okay, glucagon and insulin are then majorly working on the liver. Okay, glucagon activates the liver to be participating in gluconeogenesis and glycogenolysis to produce glucose monomers which can be released into the blood, and insulin counteracts that signal. Okay, now, if we're saying the effect of insulin binding to the insulin receptor on the cell is going to be decreased, okay, so the signaling effect of insulin binding to insulin receptors on the hepatocyte is now going to be decreased because of insulin resistance, then, even though we've got the same amount of insulin, the actual effect of it on the hepatocytes is going to be less, which means that you're going to offset the balance, basically, just as we did in type 1 diabetes. Now, the glucagon signal is going to be the same, but the insulin signal is going to be weaker. Insulin signal is going to be weaker, which now means that the net signal towards gluconeogenesis and glycogenolysis is going to become stronger. Okay, so now you're going to end up producing more glucose and releasing it into the bloodstream. Okay, and again that offsets the balance, because remember we had to release exactly the right amount of glucose into the bloodstream that was actually going to be used by the tissues such as the brain. Okay, now we're putting in more glucose than those tissues are actually going to use, and that therefore is going to cause hyperglycaemia at the fasted state, which of course it had to, even to be considered type 2 diabetes. Okay, now initially it's not actually going to happen, but I'm going to talk you through that in a moment. Okay, we're just thinking about what insulin resistance would actually do at this stage. Okay, I will talk about the fact that the beta cells can compensate for this. Okay, right. In addition, if insulin is now having less effect on the skeletal muscle cells, you're now going to get more proteolysis in the skeletal muscle cells, supplying the amino acids for gluconeogenesis. Furthermore, if insulin is having less effect on the adipocytes, you're going to get increased lipolysis of the triacylglycerols, releasing more free fatty acids into the bloodstream, and that will lead to more ketone bodies. Okay, so again, you're going to get ketonuria. Okay, right. Then let's talk about what will... sorry, not ketonuria, we haven't got there yet. Ketonemia. Okay, high ketones in the blood. We will come to ketonuria later on. Okay, right. Then let's talk about what's going to happen in the fed state. Okay, so here's our picture of what happens in the fed state. In the fed state, remember, insulin is driving the uptake of glucose by these three primary tissues, the skeletal muscle, the liver, and the adipocytes. Okay, if insulin now has less effect on each of these, then they're going to take up glucose less efficiently, okay, and that means more glucose is going to remain in the bloodstream, so it's going to start building up. So again, you're going to get problems with your postprandial glucose spikes. So they're going to get higher again, okay, because now your ability to control blood glucose level is reduced. So when the glucose is coming in from the intestine, okay, you're not going to be taking less of it out into the liver and the skeletal muscle and the adipocytes, and therefore it's going to build up to higher levels. And in addition, the spike is going to be broader as well. Okay, now it's not going to be quite as extreme in type 1 diabetes as it was in type 1 diabetes, okay, but it's still not going to be brilliant. So if I draw a graph here, okay, so firstly let's just put on the healthy subject, okay, so here is normal fasting glucose, then there is our postprandial glucose spike, okay. In someone now with type 2 diabetes, their blood glucose is going to be elevated at the fasting state, okay, and then when they eat some carbohydrate-rich food, they're going to have a bigger postprandial glucose spike, and it's also going to be broader. It's going to take longer to come back down. Okay, right. So now what I want to talk about is the fact that when you first develop insulin resistance, this doesn't actually happen straight away. Okay, so type 2 diabetes mellitus takes a long time to develop. Firstly, what's believed to happen is you're starting to develop insulin resistance, but that it doesn't cause a problem. Now, why doesn't it cause a problem? Well, the idea is that the beta cells can compensate. Okay, so there's going to be beta cell compensation. So remember, your beta cells were perfectly healthy in type 2 diabetes. They were not being attacked by some autoimmune reaction. They were perfectly healthy. Okay, now the beta cells are going to be activated by this hyperglycaemia. Remember, beta cells are activated by glucose. Okay, so they're going to start chucking out more insulin. So basically, the beta cells compensate for this problem of the tissues not responding to the insulin by increasing their output of insulin. Okay, so firstly, in the fasted state, they will be increasing their output of insulin. Okay, so remember, in the fasting state, there is usually that tonic insulin level. Okay, now what we're going to do is we're going to increase the amount of insulin we have at the tonic level, so that even though we've got insulin resistance on the level of the receptor and the signaling pathways downstream of it, okay, the increased amount of insulin will mean that more receptors are going to be activated, and therefore the amount of the signaling pathway that you'll get activated is still overall the same, and therefore you will still have this counterbalancing mechanism to counterbalance the glucagon signal, and therefore the hepatocytes will not overproduce glucose and release it into the bloodstream. Okay, so that will help combat the hyperglycemia in the fasting state, and then in the fed state, again, you'll have compensatory mechanisms. The amount of insulin that the beta cells release in response to glucose going up in the bloodstream following a meal is going to be increased, okay, so that even though the tissues are now resistant to the insulin, okay, you will still get the same response because now you've got more insulin and therefore greater activation of the insulin receptors, which, even though the ability of them to cause their downstream effect is now reduced because of the insulin resistance, because you've got more of them activated, that makes up for that problem. Okay, so initially the beta cells cope then by producing more insulin, and this is called beta cell compensation. Okay, so insulin is going to go up, and you're going to get now elevated insulin levels in your blood. Okay, so even in the fasted state, you're going to have elevated insulin, and certainly when you eat something, you're going to have insulin peaks that are beyond what they would normally be. Okay, and there's a fancy word for this. This is known as hyperinsulinemia. Okay, and it's the opposite to what happens in type 1 diabetes mellitus, where you get hypoinsulinemia. Okay, so because the beta cells have been destroyed in type 1 diabetes, you can no longer produce insulin, and therefore you get hypoinsulinemia. Okay, so they really are the opposites, but they have the same effect, basically. Okay, right. So, what goes wrong then? You initially get this insulin resistance, the beta cells handle it. What then goes wrong? Because if this was what happened, you wouldn't end up with the hyperglycaemia, and therefore you wouldn't end up with type 2 diabetes. Well, unfortunately, the beta cells, they compensate for a while, but then they seem to lose their ability to compensate. And this was originally called beta cell exhaustion, okay? In the spirit of the beta cells have been working too hard, making this extra insulin, and now they've just sort of become exhausted and died of exhaustion, basically. Well, they don't die, but they become exhausted, basically. Okay, so beta cell exhaustion. Okay, we now don't think it's necessarily the overproduction of insulin that is damaging them. Okay, so rather than calling it beta cell exhaustion, people now generally call it beta cell dysfunction. Okay, so that you don't necessarily imply that it's the overproduction of insulin, the overworking, that is damaging them. Okay. Nevertheless, what happens in beta cell dysfunction is that these beta cells, which were compensating and producing more insulin, are now going to stop doing that. They're going to go back to producing much less insulin, okay? And that then is going to produce what's known as relative insulin deficiency, because now you've got a problem. Previously, this problem of the insulin resistance was controlled by you producing more insulin. Now the beta cells have become exhausted or dysfunctional and are going to produce much less insulin. They don't stop producing insulin altogether, but they produce much less insulin. Okay, they take it back down to a more normal level. Okay, and that then is going to lead to all the problems that we've just talked about, because now you've got a normal or maybe even lower level of insulin, okay, which is coupled with this insulin resistance, and therefore it's going to cause all of the things that we've just discussed. It's going to cause the hyperglycemia when you're in the fasted state, the ketonemia, okay, and then when you're in the fed state, it's going to cause these much higher and much broader postprandial glucose spikes. Okay, right. Now let's talk about what is known or what is suspected about how insulin resistance actually emerges. Okay, so type 2 diabetes mellitus, there is a huge environmental risk factor, which is obesity. Okay, obesity and type 2 diabetes seem to pretty much always go hand in hand. People who are obese generally develop type 2 diabetes, okay? So being obese is a huge risk factor for type 2 diabetes. Okay, so it seems as though this is somehow driving the insulin resistance. So what do we understand about how obesity causes insulin resistance? Well, the problem with being obese is that if you have too many adipocytes, then when you are in the fasted state, you're going to be releasing too many free fatty acids. So let me remind you of the fasting state again. So when you're in the fasted state, insulin being low causes the adipocytes to start breaking down the triacylglycerols and releasing free fatty acids. If you have absolutely loads of adipocytes because you're obese, then they're all going to be doing this, and therefore they're all going to be releasing free fatty acids into the blood. So the rise in free fatty acids that people who are obese get in the fasted state is going to be much bigger than the rise in someone who is a normal weight. Okay, and that's believed to be the problem. Okay, if you are obese, you get the elevated free fatty acid levels when you are in the fasted state. Okay, and this is believed to underlie the problem. Now, particularly visceral obesity is considered a risk factor for type 2 diabetes over subcutaneous fat. Okay, so let me just explain what visceral obesity means. So visceral obesity means that your fat is mainly stored as what's known as visceral fat, as opposed to what's called subcutaneous fat. So let me draw you pictures of what this means. So subcutaneous fat is fat that's stored just underneath the skin. Okay, so when people have rolls of fat on their abdomen, okay, like this, I'll try and make it look a little bit more convincing. So there's the belly button, and you might have some rolls of fat like this, okay, kind of thing, okay. This is subcutaneous fat that's rolling like that, okay. This is fat that's just underneath the skin. So you'll have the skin here, let me put the different layers of the skin. So here's the dermis, here's the epidermis here. Okay, I'll colour it in to make it look more convincing. Okay, so this is the outermost layer of the skin that faces the outside world. That's the epidermis. Then underneath the epidermis you'll have the dermis here, okay, which contains the blood vessels and the nerves and the sensory organs and all sorts of things like that, and the sweat glands and other things, okay. And then underneath that you'll have a fat layer known as the subcutaneous fat layer. Okay, now that's not seen as harmful. Well, it's not seen as harmful as visceral fat. So let me explain what visceral fat is. So visceral fat is pot belly fat. Okay, so when you see someone with a huge pot belly, generally it doesn't roll like this. Generally it's much more smooth. Okay, so it looks like this kind instead. Okay, like that, and it's generally much smoother. It's not rolled over into rolls like this. Now, where is the fat in pot belly? Well, in visceral fat, it's stored in the peritoneal cavity. Okay, so that's why visceral fat is also sometimes called intraperitoneal fat. Okay, so it's stored in a very different place to subcutaneous fat. Okay, so to find the peritoneal cavity then, what you need to do is you need to go under the skin, you need to go under the subcutaneous fat, you then need to go under all of the muscles of the abdominal wall into the actual abdominal cavity. Okay, and in the abdominal cavity you have something known as the peritoneum. Okay, now let me try and explain what the peritoneum is. Basically, the peritoneum is, well, you can think of it as a balloon, effectively. Okay, it's a membrane containing a space. Okay, and I'll just draw it in a rectangle space like so, that is sitting within your abdominal cavity. Okay, so you can imagine your belly button is here, and this is your peritoneum. Okay, and the peritoneal membrane is the membrane lining this space. Okay, so it's a two-dimensional membrane. Okay, and inside the peritoneum you have peritoneal fluid and also intraperitoneal fat. Okay, now this is where visceral fat is. It's within the peritoneum, so intraperitoneal fat is visceral fat. Okay, and this is what's hugely enlarged in pot belly. You've got a huge amount of this intraperitoneal fat stored within your peritoneal cavity, and that's under your skin, under the subcutaneous fat, under all of the muscles of the abdominal wall. It's stored in there. Okay, so you can't, it doesn't roll because the abdominal muscles are making that smoothness of a pot belly, basically. Okay, so that sort of fat, pot belly fat, visceral fat, is believed to be more dangerous as far as causing type 2 diabetes is concerned than subcutaneous fat. And the reason is believed to be because visceral fat is better at breaking down triacylglycerols than subcutaneous fat. Okay, so it will more readily break down its triacylglycerols into free fatty acids and release them into the blood in response to low insulin than does subcutaneous fat. Okay, right, so obesity then causes elevated levels of free fatty acid in the blood during the fasted state. Okay, what does this then cause? Well, basically, you end up with free fatty acids going into the skeletal muscle cells and also the liver cells. Okay? So, what happens is the free fatty acids end up going into the liver cells and the skeletal muscle cells. Okay, now of course they're meant to go into the liver cells, okay, to be converted into ketone bodies. Okay, they're also meant to go into the skeletal muscle cells so that the skeletal muscle cells can oxidize them and use them as an energy source as well. But when you get too many free fatty acids going into the liver and the skeletal muscle cells, basically it seems as though the pathways for breaking them down and processing them become overloaded. Okay, and what starts to happen is the liver cells and the skeletal muscle cells start storing them like fat cells. Okay, so they convert them back into triacylglycerols, okay, TAGs, and also DAGs, diacylglycerols. Let me draw these. So we'll draw our triacylglycerol here, which is our glycerol molecule in green here, with our free acyl groups attached on, our free fatty acids attached on. And then a diacylglycerol is a glycerol molecule with just 2 acyl groups rather than 3 attached on. Okay, so here is the glycerol molecule, and here are the 2 long-chain carboxylic acids esterified on there. Okay, so liver cells and skeletal muscle cells start storing these triacylglycerols and these diacylglycerols within their cytoplasm. So let me show this. I'll draw it for a hepatocyte here. Okay, so you start getting intracytoplasmic storages of these triacylglycerols here within the hepatocytes. Okay, and also within the skeletal muscle cells. Okay, so you get intrahepatic and intramyocellular storages of these triacylglycerols and diacylglycerols. Now, these triacylglycerols and diacylglycerols are believed to cause problems with the insulin receptor signaling cascade. Okay, so we're going to get problems with insulin receptor signaling cascade, particularly the diacylglycerols are believed to cause this problem, okay, when they're located in the cytoplasm. So insulin receptor signaling is going to encounter problems because of the presence of these triacylglycerols and diacylglycerols. Okay, and that's believed to be what underlies the insulin resistance in the hepatocytes and also in the skeletal muscle cells. Okay, right. Now, we can also explain the beta cell dysfunction by the 2 high levels of free fatty acids within the bloodstream, because the free fatty acids within the bloodstream also end up going into the beta cells, okay, of the islets of Langerhans, and these beta cells also end up with stores of triacylglycerols and diacylglycerols within them, and this is believed to underlie the beta cell dysfunction that is seen within type 2 diabetes mellitus, and may be the reason that they end up producing less insulin with time. Okay, right. So, that then is type 2 diabetes mellitus. In the next video, what we'll do is turn our attention onto a monogenic form of diabetes, specifically MODY2.